to today's program titled Payer-Provider Collaboration, the Future of Healthcare. At this time, all participants are in a listen-only mode. Later, we will conduct a live question and answer session, and if you wish to ask a question live, you must be listening to this webinar on the telephone at that time. For those of you who are logged into the web presentation, you are encouraged to submit questions throughout the conference by selecting the chat pod located in the lower left corner of your screen and then type and send your question that way. For optimal sound quality, it is recommended that you listen to the conference via your telephone. Please do not forget to turn off your computer speakers if you choose to listen over the telephone. Look at the top left-hand column and click the speaker icon to turn the computer speakers on and off. And if you choose to listen to the conference through your computer speakers and you experience any problems with the internet sound quality, please dial back in on your telephone. Now I'd like to introduce our host for today's call, Steve Davis. Mr. Davis, you may begin.
Thanks, Wendy. Hello and welcome to today's program on Payer-Provider Collaboration. Today's free webinar is sponsored by Softheon. I'm Steve Davis, Managing Editor of Inside Health Insurance Exchanges and the AIS report on Blue Cross and Blue Shield plans, both of which are published by Atlantic Information Services in Washington, D.C. And according to our data, more than 270 provider-sponsored health plans are operating in the U.S., a huge increase from just a couple of years ago. For the 2016 plan year, these health plans accounted for 26% of all carriers selling coverage on the public exchanges and a majority of new Medicare Advantage plans. Today we're going to hear about payer-provider collaboration. And let me introduce our panel. With us today are Jon Kingsdale, Managing Director at Wakely Consulting, Jeff Burbank, Director of Provider Solutions at Softheon, and Softheon's founder, chairman, and CEO, Eugene Sayan. Their full bios are in your materials. If you'd like to download a copy of the slide deck, click on the Presentation tab to the left of your screen. After the presentation, we'll open it up to your questions. And with that, let me hand things over to Eugene. Hi, Eugene.
Hi, Steve. How are you?
Good. Nice to have you back.
Thank you. Thank you. It's great to be here. It's been a while since our last webinar. And hello, everyone. This is Eugene Sayan. I'm the founder, CEO of Softheon. Today we have an exciting panel, and I think it's a very lively and timely conversation about the future of healthcare as we view the payers and provider collaboration as a critical challenge, if you will. Without further ado, brief intro in case for those of you but don't think he needs an introduction, but I'm going to give you a summarized version of it. Jon Kingsdale, he was basically appointed by the Governor Romney to build Massachusetts Health Connector, also known as RomneyCare. So since he left the government, and he has been working with many public and private clients, implementation on the ACA, and now he divides his time between consulting, teaching, and research. And Jon is currently the Managing Director of Wakely Consulting. Some of you might be already working with him in his organization. And then I have Jeff Burbank. Jeff is a recent addition, and we are extremely privileged to have him on board with us. Jeff is now leading Softheon's Provider Solutions business unit, if you will. And Jeff, too, his bio is on the site, and we urge you to come in and just reach out to either one of them, including I. So without further ado, we'll proceed with our presentations today. Once again, the topic of the conversation is the payer-provider collaboration. Our agenda, for those of you, we are pleasantly surprised with the number of attendees to this conference, to this webinar. So I will take a few minutes of reorienting and reintroducing Softheon in a few slides to the audience. But before I do that, I'll turn over to Wendy with our polling question.
Okay, I'll read this question for you. Which of the following most closely matches the organization in which you are employed? And people are already responding. It'll be interesting. And we'll be, all the attendees will send the results of our polling questions. We have 3 polling questions at the after the program.
Okay, everybody, I'll give you another 10 seconds. I think we have everybody, Steve.
Okay, it's a diverse group we have, Eugene.
Yes, indeed. It is actually a little bit of a pleasant surprise, I will say. We have quite a few providers with us as well, too, which is fantastic, and we look forward to. We'll definitely, custom tailor some of our conversations around the providers as well in this topic. So our first introduction to you, Softheon is 100 plus. We have grown and continue to grow. We are a U.S.-based technology organization. Our main platform today embodies many of the critical technologies. What was once a liability, as we call it, now is our strongest asset. Areas such as real-time transaction processing, or stochastic analysis in research, and as well as big topics like big data, as well as blockchain. We also like to communicate with our health plans and providers. For those of you who have not been receiving our daily newsletter, we have put together this newsletter. It's topics around just exchanges. It's a curation of all the news happening in the industry. And of course, we will be delighted to have you among our subscribers. This is a service of a free service of Softheon, and we'd love to be able to communicate with you almost on a daily basis. We just want Softheon to be relevant in your daily conversations, hopefully. And then we view our partnerships with our health plans as a true collaboration because, as you know it, and one thing about healthcare these days, it's rapidly changing and evolving. Our challenges, what was once a success, now is being re-questioned for the new setup. So our past success does not guarantee our future success. So for that reason alone, we encourage a very open and transparent communication between us and our carrier partners. As I mentioned that to you, Softheon is the intermediary today. Our cloud platform today, it nearly 20% of our population, or from a supplier point of view, as we call it, our health plans on ACA, today they use Softheon, all the way from Centene to recently added some blue clients, as you can see. We like to keep ourselves as a neutral platform, if you will, of course, with full compliance of HIPAA and PCIs and SOC compliance and whatnot. And again, as the motto is here, is our mission statement to be the intermediary between the payer providers and giving them the freedom to market their health plans in private and public exchanges all together. We have the opportunity to really get involved with exchanges, and this goes back to our initial works with Jon and his team. Softheon team was responsible for parts of the realm the carrier implementations. And from those days on, we have built a cloud-based platform today that basically acts as we call the wholesaler from a payer's perspective. We are able to deliver these critical functions, let it be EDI gateway interfaces between the federal and state exchanges and private exchanges, or enrollment underwriting component, our remedy platform, which does that. Equity platform is our premium billings and payment and fulfillment. So we are able to create a real-time quote-to-card experience for the consumers of our health plans. Foundry is our big data repository, is also responsible of CMS Edge server compliance, including the cost share reduction. So it has the ability to adjudicate claims for the purpose of maximum.
Okay. Great, thanks. So, in terms of legislation, I think it's fair to say that you all have been hit with, an avalanche maybe, one after the other, major pieces of legislation and regulation as listed here. And that's a challenge. I don't even know ACA. Some Republican must have the number of pages of regulations that have been issued so far. I would be surprised if it was under 100,000. Maybe it's far more than that. But each of these is a major challenge, and it's a challenge both in terms of the business changes that you need to undergo and support, and including, of course, information technology. But it's also a challenge in terms of getting the information and reporting the information that each of these requirements assumes that you will have and or share with others. And so that's generating, I think, some pressure as well for provider-payer relationships to be governed by some new rules and some shared responsibilities. Clearly, these legislative and regulatory, this avalanche is impacting payers, providers, and even patients and members. And as I suggested, it looks like one way, the only way to get some of this information is, and to report it and stay on top of it, is through collaboration. If you look at the next slide, however, when it comes to value creation, we've got, particularly in the fee-for-service system, which is still the dominant form of payment, we've got some significant conflicts between payers and providers over value creation. And these are pretty familiar to everybody on the phone call, so I won't belabor them. But this is often a kind of a zero-sum game where the providers want higher reimbursement, the payers want lower. The payers want to reduce utilization, providers actually benefit generally from higher utilization. And frankly, the margin available for providers is something that payers are not particularly interested in, providers are, except, and I think that's an important exception, when we get to forms of payment that are highly aggregated and involve a lot of risk sharing. And so, and of course there is independent of its impact on payers and providers, there's a lot of interest in the policy community and more generally in aggregated forms of payment that create risk sharing and tend to align interests around value creation for wholly independent purposes in terms of quality and coordination of care. And so those are driving a lot of the collaborative efforts that we begin to see taking front stage in the healthcare scene today. So if you look, for example, at the next slide on primary care and specialty care, group consolidation, there's a lot of stuff going on here. There's a very dramatic uptick in the number of physicians, the percentage of physicians practicing in large groups. The right two bars here indicate that just in the 2.5 years between mid-2013 and the end of 2015, we've seen as much as a 5% increase in the number of primary care physicians practicing in groups of 100 to 500 and 500 or more as they shift over, and a concurrent commensurate decline in the number of solo practitioners and two-doctor practitioners. So we're all very familiar with hospital consolidation, with insurer consolidation, with or without Justice Department support for it. And it's equally true with primary care physicians as well, and specialists, and that's but particularly primary care, and that may in fact be related to some of the hospital consolidation, some other things, but it seems to be also related to, or at least enabling, physician, hospital, payer collaboration in some new and exciting ways. So if, for example, you look at the next slide, we're seeing, no surprise to anybody on the call, steady, substantial growth in the number of shared savings program ACOs over the last 3 years. We're even seeing significant numbers, to almost 200 in 2015, looking like they will be profitable. And these require tremendous payer-provider collaboration, the payer being, of course, Medicare in this instance, and some of the frustrations being around data sharing and data cooperation between Medicare and providers who are at risk. But this, of course, is far from the only form of collaboration. And if you look at the next slide, we see some of the other forms as well. So there's a variety, pay for performance, collaborative efforts between both Medicare and commercial insurers on the one hand and hospitals and physicians on the other, in which we're looking at measurement of patient care processes and outcomes, even cost as metrics for performance. A whole raft of innovations, of course, from the Centers for Medicare and Medicaid Services and Innovation, including bundled payments and ACOs and SNPs and a whole bunch of other things. And that all is really coming together in MACRA. I mean, you can actually see the MACRA as and the favored position given to alternative payment models as kind of the consolidation or endorsement of the payment reforms and experiments going on under CMMI. And of course, with MACRA, it will apply across Medicare to all physicians. And then we see the huge growth in Medicare Advantage and special needs plans, many of which involve shared risk and value-based reimbursement for providers. And with both Medicare Advantage and special needs plans, and even in the individual and small group market now, the development of risk-adjusted premiums again means that providers and payers are actually aligned around revenue. So the payer now gets more revenue for sicker, higher utilizers, and presumably is in a position to use a similar kind of risk adjustment in its pay for performance or capitation or other risk-sharing arrangements with providers. So you've got a kind of a steady stream of flow of risk-adjusted dollars from the ultimate payer, be it the taxpayer or an employer, through the health plans to the providers. And that has just tremendous implications for aligning incentives and for collaboration. Not only the need to share the data, but also the interest in actually acting in a similar way. And then, of course, with the states, a variety of states are doing a variety of innovations around risk adjustment and care coordination. Massachusetts and Oregon are out front. There's a lot of others doing it as well. But let's just, if you look at the next slide on bundled payment, just dig in to and get some specifics around what I'm referring to as payment reform driving collaboration. So think about this stack of $25,000 as a maybe typical expenditure for major joint replacement, hip or knee replacement. And you can see a bunch of it, more than half, is typically allocated to the hospital for inpatient care. But there's big chunks going to physician, to subsequent readmission, to SNF care, to follow-up hospital outpatient care or pre-surgical care, home health, even a little bit, unfortunately, to hospice. And so not only does a bundled payment in which that whole stack of disparate payments to different payers get consolidated, not only does that require collaboration between physician, hospital, anesthesiologist, physical therapists, labs, skilled nursing facilities, home health care, but it requires also significant data sharing between the payer and that group of collaborating providers, whether that sharing be around what's happening before or after the 30-day or 90-day period that defines an episode of care, 90 days usually, what's happening on the outpatient side that the hospital may not be aware of, or in the home care setting, whether there needs to be risk adjustment for the bundled payment, and most particularly, what do the outcomes look like, since they're an important piece of the reimbursement typically for bundled payment. What do the outcomes look like in terms of functional ability or disability, return to work, et cetera? None of which right now is readily available either to payer or provider, but must be newly added to the data mix. So if you look at the next slide, I've just listed a few of the data sharing requirements and elements for effective collaboration. These are obviously, to the extent that they are new and more important because of provider-payer collaborations, they put real specific needs and functionality on the table for payers and providers somehow to figure out. How do we get and share real-time more and better administrative data, such as in a capitated or shared risk arrangement, which primary care physician panels are really open. Where do we, does the data for care management, the daily list of inpatients, for example, come from? Is that from the payer to the provider, or the provider to the payer, or both? What about follow-up care for disease and chronic care registries, and then the pay-for-performance metrics that are built into these collaborative arrangements, such as penalties or rewards for moving the readmission rates up or down, for blood sugar level monitoring and impact for diabetics, etc. Risk adjustment, a critical piece that's highly data-driven, claims data-driven in general, behind really effective aggregation of risk for for global budgeting. You really can't do that in a fair way without this kind of risk adjustment data. And the payers are just as dependent on the providers for getting the episode, the incidents of care and the claims data that's accurate and detailed in order to accurately capture the risk of the population being cared for, as the providers are on the payers for ultimately bundling all that stuff together and reflecting in global capitations the relative risk of the population they're caring for. And then finally, of course, the whole cost management, whether it's dollars per member per month or utilization of services per member per month overall, or by different lines of service, critically important for providers and payers to share that. So now last slide I want to cover just kind of gives you a schematic. Maybe many people on the phones on the webinar are familiar with this, but as we move from the lower left fee-for-service towards more and more aggregated forms of payment, the potential for value creation is enhanced, and the need and potential for payer-provider collaboration is enhanced. So to the extent we think we're moving up and to the right on that line as a society, the future requirements and prospects for payer-provider collaboration, I think, are very, very strong. So with that, let me turn it back to Eugene or Jeff, whoever's coming in.
Thank you, John, as always. So proceeding on John's notion of the top challenges up there too, we will then turn over to the opportunities, and Jeff Burbank from Softheon team will provide some insight to some of our findings in that space altogether too. But before that, let's put up the last and final polling question. Steve?
Thanks, Eugene. Please describe your organization's readiness in building a successful payer-provider relationship.
Okay, I think we have everybody.
And it's interesting finding from those all that it does apply to us, and there's only one attendee has responded, says that they are neither ready or not the diligence cycle. It's no surprising, again, the majority of the memberships and among the attendees in here today, they're in the ready or the diligence cycle. So it's nearly half of the audience as well. Thank you for that insight as well too. So with that in mind, I'll turn over to Jeff Burbank. Jeff, take it away.
Absolutely. Thanks, Eugene, and thanks, John, for the insight as well. he did a great job, I think, of talking through some of the challenges. So really where we want to go next is to kind of talk about what are your opportunities? What can you do depending upon your role? And we have a mix of different people here, so we'll try to provide a few different perspectives on what you may be able to potentially do. I think the first one that we've seen, and maybe it's a little bit obvious, but there's a lot of different ways to approach it, really is within the exchanges. We are seeing, and there's a lot in the news about exchanges every day, but let's look at some of the statistics to support where exchanges are today and where they are going to continue to go in the future. So if you look at who's eligible and who has signed up and kind of the continued growth, not only from people that have enrolled, whether they re-enrolled or they're new, but also the amount of carriers that are involved in it. It is still an active market and one that we expect to continue to grow. If you look at the numbers in 2018, we see that it's going to it's going to really kind of continue, and the percentage of the population that's participating in exchanges is going to continue to grow as well. And I think what's a common thread throughout this is that, and as we've seen kind of the news headlines, the people who collaborate, whether you're a payer or a provider, the ones who collaborate effectively and have a well thought out plan are going to be the ones who have better performance and able to take advantage of it. The other thing is that the exchanges, the public exchange has kind of shown us that there is a methodology to this, and we're also starting to see it trickle down into many other models that participants, whether you're whatever type of stakeholder you are, you're going to have an opportunity to participate in an exchange-like arrangement in order to provide coverage. The other side that we're really seeing a significant amount of is, even going back to the beginning when Steve had kind of brought up some of the statistics in the beginning, you're going to see them here again, is that, the provider-sponsored health plans, there's a significant amount of growth. In only 2 years, the amount has almost tripled of providers wanting to get into the health plan space. And that really only makes sense because if you look at ACOs, there is an opportunity, the scales are tipped in their favor in terms of business arrangements to make sure that they can have they're able to offer lower premiums, they're able to share in terms of the savings that they can achieve. So it makes sense as they start to share and take on more risk and have control of those scenarios that you would want to get into what we would call kind of that Payvider space. So there's also inherently better opportunities to collaborate with the appropriate leadership and an emphasis on systems to control the information. You should be able to drive your margins higher by driving out some of those costs and having more control over your environment overall. So looking at this from the opportunities, from the impact of the different stakeholders that are involved, I think everybody understands that the ultimate goal of this is to take better care of the consumers. So what's really in it for them as we kind of move down the scale of collaboration? So I think the first one is that there's really more options. There's a term, and we were at the Oliver Wyman conference last week, and a lot of it had to do with consumerism, being able to have the consumer drive what they want and how to take care of themselves and really be empowered to make the appropriate decisions. That comes from better information that's going to be afforded to them, as well as ultimately better health all the way down the line. So the impact to stakeholders, the payer stakeholders here, really what we've seen is this all kind of has shaken out, and as I've mentioned, has come across the news headlines, is that really your performance in this arena matters. So if you're involved in the exchanges, if you jump into this market where there is an opportunity, if you don't have a good amount of collaboration between the providers and the payers, if you have poor model design or poor management offerings, or poor management of those offerings, you're going to be punished, and that's been done via losses that have been outlined and people wanting to pull out of the different markets that are there. But I think also we've seen that, and maybe it doesn't get quite as many headlines, is that if you do a good job and you're focused in this area, you're going to have an opportunity to gain market share and increase your reputation as well. Just in the last month, the CEO of Molina talked about how their initial targets really to grow from $6 to $12 billion in the first 2 years of open enrollment, and actually they think that they're going to be able to surpass their goal of $16 billion by the end of the year. So that has led to them actually saying that they're going to get into 3 new markets, taking them from 9 to 12 markets. So I think that kind of gives you the idea of, there's a lot of sort of chaos in this realm, and if you go into that with a strong strategy, you're going to be able to take advantage of that. So what that means is that your collaboration and your innovation really matters. So if you are able to program, if you're able to design strong programs, and you're able to share information effectively, whether that has to do with administrative data or that has to do with clinical documentation, risk adjustment, being able to manage that appropriately is going to give you quite a competitive advantage. The same holds true for providers. What's the impact to them? Well, their performance is going to matter as well. So when it comes to quality, you're going to be a sought-after plan if you have high-quality scores. I read an interesting fact just this morning that said that provider-sponsored health plans are actually much more likely to receive those 4 or 5-star ratings. Risk-bearing is also going to be something that's rewarded. So you can slide that scale in your favor so that if you collaborate effectively, you can negotiate stronger and therefore become more profitable and really strengthen your position in the market. And again, it goes to saying that collaboration and innovation is going to matter. So if you're able to provide rich patient information and you're able to use that information to drive strong programs, you're going to be able to become a much stronger provider or a partner, potential partner for payers. And patients are going to hear about that in their communities, and employers are going to be aware of that, and more people are going to be drawn to it, which ultimately gives you leverage as you go forward, regardless of what model you decide to choose, whether that's going to be a traditional model, you want to move into the provider-sponsored health plan realm, or however you want to approach that market. It just gives you opportunities to move your business going forward. So let's talk a little bit more about the types of collaboration that goes on. Really, it was touched on a little bit, but from a high level, what we're seeing is that there's really 2 types of collaboration you should focus on depending upon your role. One of those would be in the business side of things. So I think one of the innovative approaches that we're seeing now is programs around provider education. By using claims information, you can really understand certain pockets of your population, approach those providers, and provide better care, drive down your costs. Going to your employers, to your direct customers and saying, we can get involved on the work site. You're able to capture certain conditions earlier and do something about it. And then again, risk sharing. If you have an alignment of your financial goals and your approach overall, it's going to lead yourself to a much better situation and avoid some of the sort of headlines that we've seen here over the last year or so. When it comes to information, the opportunities for collaboration go pretty deep. I think the first one is that there's administrative information that you can share. How do you build a bridge? Obviously, this needs to be done in a secure way, but the more administrative data that you can share, the more collaboration about that information you can share, the better business-driven decisions you're going to be able to make. Clinical documentation, this is a really difficult scenario, is how do the providers present the right and appropriate clinical documentation to quantify risk scores, to make sure that they're taking advantage of any other sort of programs that they can. So getting that in an effective way and unlocking that PHI to be used in an effective business way is a really good way to collaborate that can make quite a bit of difference. We're also seeing a tremendous amount of opportunities in the data analytics space by taking that clinical documentation and administrative claims files. You can really start to outline where is the care occurring, what geographic regions do you need to provide physician education. There's just a tremendous opportunity if you're willing to collaborate up and down the chain to make it a really effective program. And then care management coordination, there's multiple ways to attack that, whether you're the payer, you're the provider, you're the employer, or the member. Those all collaborating with one another is going to lead to better outcomes overall and costs being driven from the system overall. So kind of one of the last topics really to kind of go through that I wanted to discuss really is So we're kind of seeing this already, that multiple people are going into different verticals here, whether that's what's been talked about the most here is probably the Payvider space, or we haven't really talked about the payers actually getting into integrated health systems and trying to go kind of the other way. There's really a lot of competition, and the lines of competition are becoming very gray. And I think as you consider your opportunities, it's good to know who you're competing with. There are some new business models. I think some of the newsworthy ones are new health plans that have been born out of kind of a new approach and a new idea, not necessarily the legacy model. Companies like Oscar and Bright, Oscar made a lot of headlines, but they've also had some really strong collaboration and picked certain providers to collaborate with. An exclusive sort of arrangement with Mount Sinai in New York for Oscar. Bright Health really targeted Colorado, and they really partnered with a specific provider, Centura, there. I think if you're looking at items like wellness, intervention, utilization, and consumer engagement, what you're also going to be competing with is new players into the arrangement. The concierge services like an Alignment Health or Accolade, those are companies that get involved. I think they increase the overall quality of care, but they're also competing for dollars. So if you're not going to get on top of that sort of element of care, then you're going to stand the risk of losing a portion of what you may be able to gain from it. Now, the last thing that we're seeing is also self-insurance. A lot of companies now are saying there's a lot of administrative costs associated with it. The more people we can kind of take out of the equation, the more opportunity there's going to be for us. Some statistics involved with that is that really now 61% of employers overall are self-insured. Employers, if they go self-insured, kind of general numbers are that they can save 10 to 25%. They're going to gain more control over their finances. In addition, that's always thought of as a large company sort of arrangement, but we've also seen statistics for small to medium businesses that self-funded health insurance rose from 28.5% in 1996 to 39% in 2015. So there's competition really, I think, coming from all angles, and that's important to understand. So what this means overall is that there's a need to collaborate. There's multiple ways to do it. I think a clear and conscious approach is going to be what wins, and it's got to be information-based and using data, because that will really give you a competitive advantage overall if you employ those appropriate tactics with strong leadership. So that really kind of goes through the opportunities section. So at this point, I'd like to turn it back over to Steve.
Great. Thanks very much, Jeff. And let me turn it over to Wendy to explain how to ask a question. Wendy?
Thanks, Steve. Ladies and gentlemen, at this time we'll conduct the question and answer session. To ask a question via the web presentation, please select the chat pod located in the lower left corner of your screen, then type and send your question that way. If you'd like to ask a question via the telephone, please press *1 on your telephone now. You'll be placed in the queue in the order received. If your question has been answered or you wish to remove yourself from the queue, please press *1 again. I'll announce each caller prior to bringing you into the conference. Please remember that if you have your phone on mute, that you take it off mute when you're selected to ask a question. So once again, to ask a question via the web presentation, please select the chat pod located in the lower left corner of your screen and then type and send your question that way. And Steve, we're ready to begin.
Great. Thanks, Wendy. Question number 1, there seems to be a significant rise in the number of provider-sponsored health plans between 2014 and 2016. That's something I mentioned at the beginning of the program, and then Jeff, you mentioned it as well. But what's causing the increase? Why are health systems launching these provider-sponsored health plans?
I mean, I'll take this one. I think if you look at it, when it came out, when the first legislation kind of was established to go through ACOs, I think it really got providers thinking along these lines that, okay, we need to really manage this process and kind of get in the business of controlling these costs. So as you look down the continuum of kind of how do you graduate as an ACO from one level to the next, you're continuing to take on more and more risk. At some point, if you're willing to take on enough risk and you think you're good at risk, you might as well take all the risk, and that means running your own plan. So I think that's one of the main reasons why. I also think that just in general, a lot of providers would say that having that control and having the touch from start to finish, if they've got the inherent systems working together, and they've got leadership, there's just less factors involved, and they should, in theory, be able to manage the process better. So many providers wanting to take on risk, take advantage of it, is why I think that there's been such a growth over the last couple of years.
Okay, thanks, Jeff.
Steve?
Sure.
Can I jump in? This is John with an
Absolutely, John.
thought. So two additional factors I think may be at play in some of these provider-sponsored health plans. And of course, this is not a totally new phenomenon. A lot of even the original HMOs back in the early 1980s and late 70s under the HMO Act were provider-sponsored. And one of the problems that I think providers face as payment changes is getting caught in with their legs in two different sort of parts of the map and being torn apart. So the ultimate pain point is having 50% of your payment be fee-for-service and volume driven, and 50% of it being shared risk and driven by managing and coordinating care, and then you're like a schizophrenic kid. So part of what may be driving this is providers who want to make the transition being able to expedite the speed of that transition from less aggregated to more aggregated risk-sharing payment arrangements by virtue of controlling their own health plan. I think there's also a sense that if providers are going to have to give payment concessions in order to make these risk arrangements work, why not be on both sides of the transaction and, in effect, give payment concessions to themselves as health plans? So I think those are also probably at work here.
Good. Thanks, John. Let's move on to the next question. Right now, typically bundled payments outside of Medicare DRGs don't include pharmaceutical products. Do you think they will begin in the near future? I'm not sure who would like to take that one.
Well, I'll just throw one thought out, which is that, of course, the bundle payments don't yet, but I think down the road as we expand the number of procedures that could involve bundle payments, and I'm thinking about particularly surgical interventions where the surgery is an alternative to medicine, whether that's prostate cancer or back pain or something else. You could well imagine medicine, prescription drugs being factored in. One of the problems, though, of course, is the length of time, the time frame for prescription therapy, prescription medicine therapy, and for surgery are very, very different. So if you're looking at a payment per corrective surgery for back pain versus medication, it's hard to do that in a 90-day time frame.
Thanks, John. Another question here. Maybe we can send this one to Eugene. We haven't heard from you yet in the Q&A, Eugene. Can you explain how collaboration and data analytics can develop into competitive advantages?
Sure. Also ties into the first question, the phenomena around the provider-sponsored health plans altogether. If you look into the landscape of what's really kind of ACA is forcing both on the payer side and provider side to reevaluate the current set of business practices, technology, people, everything what we deem to be as an asset altogether to what really became an underlying, I will call the fact across the entire spectrum. Now that now we are dealing with millions of individuals, and by all estimates, it will be about somewhere in the 20 million. Servicing to those individuals, it's proven to be a big challenge. You're looking at the nationals, Aetnas and Uniteds of the world. We realize that business model has a lot of challenges, and henceforth we are hearing that they are exiting the ACA in general. And really what it means is that they are evaluating their overall approach to the consumerism altogether at the individual level. Then you're looking to the success of Molina and Centene and the other type of other type of organization who has been serving the memberships at a local. So hence the underlying the notion of that healthcare is local. Really, the data is what makes everything is possible in our view. All the way from evaluating the level of integrations and from fee-for-services to the capitations. These are all data-driven decisions. Going back to 2008 when we first got involved with Care, we kind of sensed that healthcare is going to be changing and changing very fast. Fast forward, nearly 10 years later, having worked with some of those most successful payers in the ACA, having also worked with many of the co-ops, even IU Health, as I mentioned earlier, we have a very unique visibility and insight to the processes. And what we see and over, the consistent theme is about data, is about analytics. It is about basically using the data as a means of closing the loop from product design, lessons learned, bring that lessons learned, and year after year, and refining the processes altogether too. So if you look into that landscape, the organization who has embraced data, who embraced risk management rather than being a risk adverse or risk avoiders, are the ones that are succeeding and will continue to succeed in the landscape. And if you look into the Oscars of the world, the Bright Health of the world, what you are finding is basically data-driven organizations. They are utilizing the importance of the data to better understand and better manage risk and better serve the population. So that has been the kind of the overarching theme across every one of our engagements with every one of our carriers.
Thanks, Eugene. And somebody is asking a little bit about the selling points for provider-sponsored health plans. I'll just read her question, or read the question quickly. Given the so-called failure of HMOs in the past decades, why are the companies offering a very similar product to HMOs? Patients' preferences moved away from low-premium, narrow network health plans with the worry that they will not get enough care. With the case of provider-sponsored health plans, since the payer and provider are on the same side, they will be concerned even more about not receiving the necessary care. Is information sharing the only selling point, and who are the targeted purchasers of provider-sponsored health plans?
This is John. I'll just throw a comment in that's tangentially responsive. There's a lot of assumptions built into that question. So I think about Kaiser or Geisinger or Intermountain and a lot of other provider-sponsored health plans as being very popular and very successful with at least some people. If you're in California, you either hate or love Kaiser. So there's plenty of negative stories about Kaiser, but there's plenty of positive stories. I think that there is a significant market for this kind of arrangement, and certainly with the greater price sensitivity that has been demonstrated in the exchanges, there is maybe an interest in providers taking the reins, and if costs are going to be really tightly managed, having that done by responsible physicians and other clinicians rather than by somewhat removed health plan executives. That would be my thought about why there might be some interest in this.
Thanks, John. Let's move on to another question. Your presentation went into great detail on collaboration. What aspect of payer and provider relationships has seen the greatest growth? I'd like to take that one. Jeff, any thoughts on that?
Yeah, I think really the parts of collaboration that's seen the greatest amount of growth is really information. So being able to take as I kind of mentioned, the administrative information, put that to use, and then kind of bring it back the other way, back to the provider, and ultimately back down to the patient themselves. That's of the greatest interest, but it's also of the greatest challenge in many ways. So all of those factors together, I think by trying to build in some agility into the system and trying to take out some of the legacy sorts of platforms that are there and trying to work with those as best you can, that's the most interest and I think of the most value. So being able to attack those problems, I think, is is a really important piece and of the most interesting and the most activity that we see is just trying to modernize a lot of those things.
So just to add on to some of the comments from Jeff is that in our view, and it was one of the obvious questions and answers that we saw today, was that sustainability was the key concern in both payers and providers' eyes altogether. One of our projects, in fact, in here, we tokened it as a notion of what we call it a member-level profit loss. We are able to today calculate a member-level profit loss statement for a given member, which means that we are able to take the income aspect of it, if you will, the member premiums and so on and so forth, and crosswalk and tabulate that against the claims information. Well, having that information in our fingertips, it enables the health plans and providers thereafter is to create a very unique experiences for that local individuals in the market. So let it go back into the initial benefit and product designs, more towards capitations and perhaps more towards high deductible health plans, narrow network designs. And again, those are the topics I'm going to leave it out, John, to talk more maybe in some subsequent webinars to discuss it, because each and every one of those topics are really as a phenomenon evolved out of the ACA. It now is in the front runner and front burner, if you will, of every payers and providers to help them deliver those services, but deliver in a way that is sustainable and that is profitable from the all participants' point of view. Still, the consumer being the central to the focus altogether, but ultimately what we are seeing in the experience of, like the Tennessee is asking to push exiting certain Blue Cross Tennessee exiting certain markets, if you will, and realigning their 100,000 plus memberships in those markets. This is a data-driven initiative between the payers and providers because ultimately it is a risk that needs to be burdened and bear by multiple parties.
Thanks, Eugene. We've got time for one more question. Somebody asked, do you think the large payers will soon acquire large health systems? Who'd like that one?
I'll turn over to John again, maybe quickly. In our view, I don't think that is really the model. One of the things that we also talk about is we call the supply chain transformation in a little bit more details, as everybody talks about digital transformation. To us is really what consumerism has done it, just like any other industry, let it be banking, financial services, travel industry, that what we are going to start seeing is basically organizations itself positioning themselves as a supplier. And there are going to be some organizations that are going to be in the supply chain as a value-added product and services, and then there is the retail experience consumer. In fact, this kind of backs into a very famous white paper was put out by PwC titled $5 PMPM health plans in your neighborhoods. So the notion is that I think what we're going to start seeing that both in the hospital provider space and as well as in the payer space, the organizations really positioning, jockeying themselves into the right position in that supply chain and really evaluating their core competencies. Is the core competencies in the brand? Is it in the services or is it in the marketing and selling component altogether? As the supply chain transforms itself, I think we're going to start seeing in fact, maybe rather than a mergers of it all together, but more like a divide and conquer method, if you will, and certain plans will be gravitating in certain space in that quote-unquote the supply chain conveyor belt so that they are able to create and maintain a sustainable business going forward, not just for a given market opportunity, which is the current model, is more like, as we call it, a farmer's market approach, what most of the payers and providers doing, where the future model is going to be about building an ecosystem, mitigating and dispersing the risk, if you will, and being a key player rather than being a mile wide, inch deep, as we call it, being an inch wide, mile deep player with a certain level of core competencies and value propositions that is also sustainable to the growth of the organization. John, you want to add anything, or Jeff, back to you.
No, thanks.
Oh, I think I'm good.
Okay, well, we're at the top of the hour and some really great questions. Sorry that we weren't able to get to all of them. I suspect our friends at Softheon will respond to your questions if we didn't get to them today. I'd like to thank Jeff and John and Eugene. And Eugene, I'd like to turn it over to you for your closing thoughts. And if we've got one more question that you'd probably like to answer in your closing remarks. Somebody asks, I don't understand exactly what Softheon does to enable payer-provider collaboration. Can you explain briefly what you guys do in that area?
Well, I think this will piggyback into the thing. Like, for instance, one of the things that we do, having worked with many provider-sponsored health plans and the payers and some thought leaders such as Jon Kingsdale, and recently we had the opportunity to have, in fact, 30 or plus C-suite execs from diverse backgrounds to come in as a kind of an invitation-only event, and we were able to discuss the current state and lessons learned and the future of healthcare. I think we as a Softheon, as a company, we're very committed. This is a company that I'm very proud of, our great minds of 100-plus people here that work with degrees in computer science or Ph.D.s and whatnot, about designing really the future of healthcare rather than another incremental solution or incremental upgrade to what has been the platform to deliver these services and products to the market altogether too. So our key role in here, the role that we play, is that able to share and build best practices and able to communicate with all parties that are involved within the supply chain transformation, as we call it. So clearly, providers are a critical component of the element altogether. Payers able to create a sustainable business model servicing, but ultimately the consumer. Consumer is the one that is going to get benefit from this in a way, but also has been historically in a disfranchised from the entire process. So creating this collaborative environment, able to bring best practices, and where the organization is able to step up to their core competency. Softheon Cloud, exactly, that's what it does today. Today we're serving 60-plus payers and providers, serving 1.8 million lives in both public and private exchanges. So we, by definition, we are one of the leaders, if not the leader, in the space of cloud computing and big data and new technologies. And one more thing, that if for those of you who've been able to follow us on the Twitters and whatnot, one of our recent topic area we are focusing extensively is blockchain. So blockchain is another key technology that we like to look at it and adapt it into healthcare. As you know, the medical records and electronic health records has been a very big of a disappointment, if you will, where it has the biggest potentials. Now, with the advent of technology, with the advent of ACA as the driving force, we are bringing blockchain-like technologies into the light, whereby the electronic medical records, claims, and other relevant important PHI information can be readily shared across all the parties within the healthcare supply chain. Of course, that to a great extent that includes our payers and provider space altogether. So one more time to thank you, our attendees, for making the time or to join us. We know how busy you are in the eves of open enrollment coming up very fast and furious. And we will love to stay in touch and look forward to hearing your questions, comments, and feedbacks. And we are looking for ways to be a better company, better partner to you. So thank you one more time, and thank you to you, Steve, and your team for giving us the platform to reach out and share these ideas and thoughts.
Thanks, Eugene. Always some interesting information. Again, thank you to our attendees and to our panel. Have a nice day, and goodbye.